Our next speaker is a Canadian who played competitive hockey up through the junior A level. He is currently a professor of neurology at the Mayo Clinic, highly published author, and Dr. David Dodick will talk to you on the metabolic cascade and pathophysiology of concussion, a view of the hockey player's experiences. David?
Thank you, Bob. Sorry I'm the only non-Bostonian here in this section, but I promised to root for the Bruins tonight. I want to thank Mike and Ainsley for the invitation and for making me a part of this, and I applaud them for their vision and commitment to this and for pulling this together. When I was about to prepare this talk, Ainsley, in her inimitable way and in her beautiful Canadian accent, try not to be too intense, eh? And if you can somehow weave in an explanation of the biology of why these people look like they have migraine after these concussions, please do that. So I'll try to oblige, Ainsley. Now, let's see. Keyboard. Oh, there it is. So one of my mentors at the University of Toronto once told me, people really don't listen to what you say during a lecture. And remember, when you speak to people, a lecture is really the process by which words flow from the mouth of the speaker into the ears of the listener without going through the minds of either. So tell them what you want to tell them straight up front. Let them go to sleep for the rest of the lecture, and then wake them up to say in conclusion. So I'm going to tell you what basically I'm going to tell you over the next 15 minutes, and that is one of the take-home messages that a concussed brain is in an energy metabolic crisis with potential loss of microstructural, neuronal, axonal integrity, and I'm sure Dr. McKee will discuss that in much more depth after I speak. The recovery of the metabolic brain damage lags behind symptom resolution. And I think this is really important because we've developed sophisticated methods to evaluate clinically these athletes, but make no mistake, according to some of the sophisticated imaging modalities that are currently available, the recovery of the metabolic brain damage certainly seems to lag behind complete symptom resolution. So just because the athlete performs well on all of our bedside tests and neuropsychological imbalance tests doesn't mean that their brain is back to normal. Subsequent concussions before metabolic recovery occurs may prolong recovery, or worse, it could lead to permanent damage with neurological sequelae. And then finally, return to play guidelines, I believe, will need to someday incorporate objective imaging measures of metabolic and structural recovery, because clearly bedside testing is probably not sufficient for at least some of these athletes. So this is where I'm going to get just intense for just a moment to talk about the neurometabolic cascade, because that's what I've been asked to speak about. But basically, you can think of it as a problem with supply and demand. The brain is in great need of energy, and unfortunately, its legs have been taken out from under it, and it's crippled to supply the energy that the brain is demanding. So essentially, initially, when the head is concussed, when the brain is concussed, I should say, there's an intense depolarization or activation of neuronal and glial membranes, otherwise known as cortical spreading depression. And you can see that illustrated up here with this nerve terminal right here. There's intense neurotransmitter release, particularly glutamate. And then you can see its effect on the subsequent neuronal cell body here. So there's massive release of potassium. And then up here, there's pumps, ion pumps. So the cell works very hard in trying to pump that potassium back in, get all the sodium and calcium back out of the cell. So that's where the energy demand is pent up. Unfortunately, and during that period of time, of course, there's hyperglycolysis. It's a lot of glucose, right? Because that's the metabolic energy for the cell. A lot of glucose being metabolized, an increase in lactate production, so lactic acidosis occurs, and that's not good for the brain. And of course, as sodium rushes into a cell and glutamate opens up all of its channels, calcium rushes into a cell, and generally speaking, an influx of calcium to this degree that occurs in concussive brain injuries is not good. Particularly not good for this structure right here. Somehow this doesn't seem to work for me, but that red structure there is the battery of the cell, which is the mitochondria, which produces the energy that those pumps require. So calcium gets sequestered within that mitochondrial organelle and actually leads to a reduction in ATP, which is the energy source. So you've got a battery producing energy that's giving it to the pumps to maintain normal ionic distribution across the cell membrane. And then finally, if this progresses to a sufficient extent, you get different enzymes that are activated, free radicals are produced, and you get cell death or apoptosis of the cell. That's the worst case scenario, of course. The other thing that can occur is just as calcium comes into the cell body itself, it can also come into the axon. And when that occurs, you get swelling of the axon, and if there's enough inflammation and swelling, you'll get actual disruption of the axon. And the axon, of course, is that filamentous thread that comes out of the cell body that allows one neuron to communicate with another. Now, in rats, we're not rats, but in rats, this has been very well worked out by Giza and Hovda, and this comes from their paper. But essentially, most of what I just said that occurs within hours, or within minutes, at least in the rat. But there are changes that may take days in the rat to recover from, and that is the increase in intracellular calcium, and you can see that blue line there, a reduction in cerebral blood flow. So just as energy demands have peaked in the cell, you get a reduction in glucose supply, and you get a reduction in cerebral blood flow that brings glucose and oxygen to the cell. Now, while that takes days to recover in animals, it takes perhaps weeks to months to recover in humans. And that's an important point. So here we are. We have a young athlete with a concussed brain. Ultimately, we want to get to recovery. But we don't want to get to the point where there's axonal disruption or cell death. But how do we know in this athlete in front of us whether or not they're headed that way? And how long we have to keep this athlete from returning to play? So there are some sophisticated imaging tools which you're going to hear a little bit about. And right now, I think rather than serum biomarkers, I think these are the real biomarkers that going forward we're going to have to implement in terms of knowing when it's actually safe to return athletes to play. So this is proton NMR spectroscopy. And what it does is it measures a variety of chemicals in the brain. It's basically a glimpse, a live glimpse at the metabolic integrity of the brain. And one of the most important compounds or molecules that it identifies is what's known as NAA, which is a marker of neuronal integrity and vitality, and it reflects mitochondrial-related cerebral energy metabolism. So that battery that I showed you that produces ATP, really a reflection of that integrity of the cell and integrity of the energy supply, looks at NAA. Choline is another important marker, which is a marker of neuronal damage and membrane turnover. And then creatine is an energy marker. So creatine is really a reflection of how much energy, how much ATP the cell is producing. And oftentimes when you look at spectroscopy, you'll see NAA to choline and choline to creatine ratios. And they reflect cell breakdown and neuronal integrity. Important thing about NAA is that it correlates with recovery of other metabolites. And so there are studies in the literature which suggest that NMR spectroscopy, particularly looking at NAA, may be a useful tool in guiding when the brain has metabolically returned to full recovery. So here's an example of an athlete, of normal control up at the top, and you can see the peak of NAA, choline, and creatine. And here you can see down at the bottom on the left-hand corner a concussed athlete, and you can see that the NAA to creatinine ratios up at the top, 2.04, 2.03, have dropped in this singly concussed athlete to about 1.65. So you can see the changes in the peaks and in the ratios. So there's neuronal integrity is disrupted here. And you can see that in this same singly concussed athlete at 30 days, these peaks return to normal. So you can actually know when the brain has metabolically recovered. Not when the athlete is asymptomatic necessarily or the athlete's recovered, but when the brain is recovered. And I think we have to sort of shift our mind conceptually to be thinking about when the brain has recovered rather than when the athlete recovers or when the athlete says he or she is recovered. Now, here's an important slide, I believe. On the left-hand side, the black along the y-axis are normal controls. And you can see here on the left-hand side, just down at the bottom here, these are singly and doubly concussed athletes. So in the hollow circles, we have a single concussed athlete. In the diamonds, we have a double concussed athlete. And we're looking at NAA to creatinine ratios. So basically, we're looking at neuronal integrity with spectroscopy. And you can see there's a reduction in all athletes who received a concussive head injury when imaging was done around day 3. And interestingly, all athletes reported complete symptom resolution at day 3. So all of these athletes were now normal, and yet when you look at spectroscopy, their brain metabolism was far from normal. Now, a second concussion occurred 10 to 13 days after the first concussion in a substantial number of these athletes. And now you can see what's happened. At day 15, some of the athletes who were singly concussed are back to normal. but some aren't, and certainly the doubly concussed athletes are still not normal. Now let's go out to day 30. In the singly concussed athletes, their brain has already returned to normal. So metabolically, these singly concussed athletes are returned to normal, despite the fact that at 3 days they said they were normal. In the doubly concussed athletes, none of them were back to normal. And then finally, by day 45, those individuals who had 2 concussions within a period of about 2 weeks were finally back to normal. So I think this is important and tells us that actual brain metabolism, the recovery of the brain itself, may lag significantly behind actual symptom resolution. And this is an experiment that was done in animals showing that when you separate concussions by only 3 to 5 days, you get a significant decrease in all of these energy metabolites that I talked about. And the shorter you put those concussive head injuries together, the less likely there is to be full recovery. Dr. McKee, I'm sure, will talk at great lengths about this, but what you see up here is a white matter stained with amyloid precursor protein, which is a marker of axonal disruption. And you can see that with a single concussive head injury, in animals at least, you get multiple axons staining with beta amyloid precursor protein, indicating axonal disruption. And that's just with a single concussion. If you repeat the concussion within 3 to 5 days, you can see on the right-hand side here, the number of axons staining now for beta amyloid precursor protein has increased quite significantly. So you can see axonal integrity in addition to neuronal integrity is compromised. And we can see that now with diffusion tensor imaging, which is really a takeoff of diffusion-weighted imaging using MRI techniques. And diffusion tensor imaging measures the degree and diffusion of water along white matter tracts and is a measure of axonal integrity, right? So think about it, driving down the highway, all the water molecules should be moving along the axons in one direction, right? They shouldn't be moving in all different directions like they do in Phoenix. And that's basically what we're looking at here. And interestingly, diffusion tensor imaging changes correlate with the histological findings I just showed you in animal models. So the very changes we see in diffusion tensor imaging when we look at animals, you see that axonal disruption, the staining for beta amyloid precursor protein, we can see that on diffusion tensor imaging. So likely similar changes are occurring in the human brain as well. Now these recover in many athletes or in many people with traumatic head injury, suggesting that DTI can also be a biomarker for recovery. Because with spectroscopy, we're looking at the metabolic brain, we're looking at neuronal integrity. With this imaging modality, we're looking at white matter integrity, and as other speakers have said, the connectivity. So this was a study that was published not too long ago showing mild in light gray on the left compared to moderates to severe traumatic brain injury. And what they showed was that the loss of white matter integrity correlates with cognitive impairment, and that these diffusion tensor imaging changes occur even in people who had one single mild traumatic brain injury. And the most important point is that these diffusion tensor imaging changes, even in mildly traumatic brain injured individuals, this is at 6 months, right? When these individuals think that they're back to normal, but when you look at their neuropsychological testing in terms of executive function, memory, attention, they're not back to normal, nor is their diffusion tensor imaging back to normal. Now the question is, would you ever return an athlete who you had this sort of objective imaging marker back to return to play, even though they're telling you that they're normal? Now a little bit briefly on headache, since headache is the most prominent symptom of concussion. Now, if I put these symptoms up here, any of you looking at this who evaluates patients with concussion would say, well, that looks like every concussion patient I see, which it does, but spend a day in my clinic and this looks like every migraine patient that you see. So why this symptom overlap? Why is it so complete? And it has to do basically with the similar pathophysiology. Migraine has a very similar pathophysiology to what's occurring in a concussed brain. So what I'm showing you here are all of the mutations that have thus far been shown in migraine. Up at the top, there was a study published just last week which identified the first mutation for migraine with aura, and it's in the potassium channel. All the other mutations in familial hemiplegic migraine are in voltage-gated calcium channels, sodium channels, or in that sodium ATPase pump that I talked about that's responsible for maintaining ionic flux. So what happens when you mutate all these channels? What happens is you get that increase in extracellular potassium, you get an increase in extracellular glutamate, and you get cortical spreading depression. Exactly what you get in a concussed brain. So who cares? Well, why would that cause headache? Well, this is a PET image of a patient actually in a scanner who's having a migraine attack. And you can see those blood flow changes that occur starting at the occipital cortex, traveling across contiguous areas of cortex into the temporal and parietal lobes. It's sped up for the purposes of illustration. It's only going at a rate of about 3 millimeters per minute. But what this is cortical spreading depression. And what cortical spreading depression does in the middle is it releases lots of things, glutamate, nitric oxide, potassium ions, etc. All of those things that it releases basically produces a chemical soup, which when you bathe the brain, particularly blood vessels and dura mater, which are the areas of the brain that are pain sensitive, when you bathe it in that inflammatory soup, you get on the right-hand side here activation of the trigeminal neurons. So you get pain in the head. And the other thing about migraine and CSD is this is from an animal, but when you get CSD traveling across the brain, a lot of energy demand for all those cells depolarizing, a reduction in cerebral blood flow. So that's what I talked about being cut off at the knees. You require more energy, you reduce blood flow, and you're crippling the brain because you're not supplying the energy that it needs. And what happens is you see here, down here, this was before CSD and during CSD, and you see axonal disruption and loss of integrity of the actual axon. Why does light and exertion make the head hurt more? How many concussed athletes do you see that they complain of photophobia? They could never be here with these lights, and every time they exert themselves or even bend over, their pain increases. There's very good explanations for this. Once you activate trigeminal neurons, and once the thalamus, which receives that input, becomes sensitized, we have retinal ganglion cells at the back of our eye, and when light shines into the back of these, there's a straight shot back to the thalamus. So if that thalamic neuron that's receiving a pain fiber that comes from the blood vessel is sensitized, right, every time you shine light in the eye, it activates that neuron. The pain gets worse. And that's been well worked out. The other thing is, whenever you exercise, you increase pulse pressure, right? Or whenever you bend over, you increase intracranial pressure. Now, all those nerve endings that are embedded in the cerebral blood vessels, as I stand here right now, I don't have a headache, even though my blood vessels are pulsing. But when they're sensitized, those nerve endings, because they were bathed in that soup, every pulsation of the blood vessel, especially if I do that, is going to magnify the pain. So there's very good physiological explanations for why these concussed athletes have headache that looks exactly like migraine, and why they complain that light and exertion makes their headache worse. So I've told you what I told you. Probably went a little bit over. I apologize for that. But the bottom line is that I think the most important thing that I think I've told you is that the brain takes a longer period of time to recover than perhaps the athlete. So the athlete may report that they're improved, your bedside testing says that they're improved, but the brain may not have been fully recovered, both metabolically and structurally. And that I think eventually we're going to have to do more research on this to see how well these changes in imaging correlate with outcome, but we're going to have to be implementing more objective markers to determine when the brain has actually structurally and metabolically recovered to know when to best return that athlete back to play. Thank you very much.